Dear students, we are in for an exciting session of Super Specialty NEET 2024 question, Plastic Surgery Revision. I am Dr. Vijay Jagannathan, your esteemed faculty for plastic surgery. So the first question was, they had given a picture of Thompson's procedure and they have asked about which is a true statement. Okay. I will say Thompson's procedure, you can all know that it is from filariasis, and Thompson's procedure is one of the excisional procedures of lymphedema or even lymphedema as such. Okay. Let me go through the various points of lymphedema. 1 minute just after that, I will just answer it. Okay. So lymphedema can be primary lymphedema and secondary lymphedema. If the onset is without any secondary diseases, it is called as a primary lymphedema. The most common form of primary lymphedema is primary lymphedema precox, and that is nearly 80%. And the cutaneous tarda, the congenital and the tarda lymphedemas account for the next 10%, 10 plus 10, 20% of the primary lymphedemas. Okay. Primary lymphedemas can be classified by the age of onset and the presence of familial clustering. So congenital lymphedema means any lymphedema that occurs in the 1 year period. So less than 1 years of age. And if it is familial, it is Milroy's disease. From 1 year up to 35 years, if a primary lymphedema comes, it is called as lymphedema precox. The familial version is called as the Meeks syndrome. And lymphedema, primary lymphedema, after 35 years of age is called as the lymphedema tarda. Whereas secondary lymphedema worldwide, most common causes lymphatic filariasis because of infestation of Wuchereria bancrofti. But if at all the most common cause for the developed countries is being asked, it is resection or ablation of the lymph nodes, either by cancer surgery like block dissections, lymph node dissections, or radiotherapy, or sometimes even tumor invasions, or sometimes due to surgical trauma or direct trauma. Okay. So for patients with lymphedema, and if it is, we don't know whether it's a primary or a secondary, the best diagnostic modality is lymphoscintigraphy. Lymphoscintigraphy basically doesn't differentiate between primary lymphedema and secondary lymphedema, but the 70 to 90% of sensitivity and nearly 100% of specificity is very useful in differentiating this lymphedema from other causes of pedal edema. Basically, what is done in lymphoscintigraphy is a tracer dye is given, and uh, the clearance level, the time taken for the clearance of this tracer dye is basically quantified. Okay, and at 30 minutes and 60 minutes, it is measured, and therefore the lymphatic function of the lower limb is measured. So, operative treatment, whether it is a primary lymphedema or secondary lymphedema, medical treatment like complete decongestive therapy, manual compression bandage, limb elevation, care of the lower limb, moisturization, and to see the intertrigo web spaces. These are all standard, whether it is a primary or a secondary. Other than that, if we want to discuss about the operative lymphedema, there are two main types of operative lymphedema, operative surgeries for lymphedema. And it is mainly considered for stage 2 and stage 3 diseases, wherein there is severe functional impairment, recurrent lymphangitis episodes, and severe pain despite the medical therapy. Okay, the two main treatments are reconstructive and excisional lymphedema surgeries. Reconstructive options are reconstructing the lymphatic channels. So this can be done only in cases wherein the proximal obstruction of the lymphatic circulation is seen with preservation of the dilated lymphatics in the periphery. If the peripheral lymphatics are destroyed, then nothing can be done. Okay, the residual dilated lymphatics are anastomosed to the nearby veins or bypassed, or even lymphatic anastomosis is done. Okay, so lymphovenous anastomosis, lymphatico-venous anastomosis, and bypass and the lymphatico bypass surgeries are the various known functional surgeries. Improvement wise, 30 to 80 degrees improvement is seen in the condition, and nearly 80% reduction in volume is also seen. So this is a picture given in the Sabiston, and you can see here. Sorry, here you can see in the picture A, the lymphatic venous anastomosis is there, and B is the nodovenous. B is the lymphovenous anastomosis, and C is the invagination of multiple lymphatics into the veins. When it comes to the excisional operations, here patients without residual lymphatics of adequate size for reconstructive procedures are mainly chosen. So, indication wise, recalcitrant stage 2 and early stage 3 lymphedema, wherein the edema is moderate and the skin is good, are mainly indicated for excisional operation. The skin is very bad with ulcerations, with varicosities, with nodularities, hyperpigmentation. It's quite tough to do excisional operations because you can face failures. Okay. So, an excisional procedure mainly removes a large segment of the lymphadematous subcutaneous tissues. First of all, such a palliative procedure was told by Condolion in 1918, and Homan developed on this procedure and called it as a staged subcutaneous excision underneath of the flaps. So, it is done in two stages. In the first stage, medially an incision is put. 5 centimeter of flaps are created anteriorly and posteriorly, and you can see here this amount of the subcutaneous tissue is removed, and this flap is also excised regarding how much amount of redundant skin is there, and finally closed. And after 3 to 6 months, in the lateral aspect, the same procedure is repeated. This is called as the Homan's procedure. 80% has a long-lasting reduction in the extremity size associated with improved function and the contour. But of course, 10% of the patient did have complications. So, Condolian procedure was the first, which was developed by Homan. And this is the Homan, and this question also, the Homan's procedure only is asked. So, Homan's procedure is nothing but staged subcutaneous excision. It's not the dermal wig flap. The other procedure is a very debilitating procedure, the Charles operation. It involves complete excision of the skin and the subcutaneous tissues and the deep fascia and the grafting of this area. So, contour deformity is too much, and distal foot lymphedema graft loss is very high. And note it, since the deep fascia is gone, the contouring is very bad. Whereas in Homan's procedure, you can very well see the deep fascia is intact, only the subcutaneous tissue is removed. Now, with this background knowledge, if you see, okay, so Thompson's procedure, pilonidal sinus is not the common complication. So cosmetics is better than Homan. Okay, and Homan is a modification of Thompson's, and it is also called as a buried subdermal flap. So mostly the D option will be the right option. Which procedure for the cleft palate maintains the levator sling without raising the mucoperiosteal flaps? Cleft palate is basically there is a functional problem in the functional problem of the cleft palate muscles, and there are feeding difficulties. Okay, there is a disruption of the velopharyngeal port, and subsequently there is a speech dysfunction also. The primary goals of palatoplasty are to separate the oral and nasal cavities and create a potent velopharyngeal port. This creation of the potent velopharyngeal port is mainly by reconstituting the levator sling. Out of the various muscles, the levator palati is the most important muscle, which is causing the elevation of the palate, which creates a genu and therefore produces the sound. So, reconstitution of the levator palate is one of the most important procedure in cleft palate surgeries, and this is the uh, the reconstituting the levator palate can be done only in soft palate, whereas in hard palate it is just a mechanical separation between the nasal and the oral cavities, whereas in the soft palate only there is reconstitution of the levator palate. Now, the question is about which procedure is done maintains the levator sling without raising mucoperiosteal flaps. I would like to say all the hard palate procedures like von Langenbach's procedure, Theo Wardell Kilner's procedure, Bardak's procedure raises a mucoperiosteal flap. Whereas Furlow's double opposing Z-plasty is an intravelar veloplasty and it is mainly done for soft palate cleft only, not for a hard palate cleft. So my obvious answer is double Z palatoplasty. Let us go through the various hard palate and the soft palate closure techniques. Okay, so like I told, all the hard palate closure techniques involves raising of a mucoperiosteal flaps. It is supplied primarily by the greater palatine vessels, and it subperiosteal elevation is done by a hydrodissection, and the oral and the nasal layer are separately created. The flaps are transposed, and the defect is closed. So let us see Von Langenbach technique. Here you can see uh, two lateral incisions are given medial to the alveolar ridge. So this is the alveolar ridge. So two medial incisions are given here. Okay, lateral incisions medial to the alveolar ridge is given, and the flaps are elevated and closed in the midline. Of course, here also a levator sling is reconstituted by intravelar veloplasty, but this is a procedure wherein it closes the hard palate. In VWK, Bio-Wardle and Kilner procedure. Bio-Wardle and Kilner procedure. Sorry for the spelling mistake. Here, again, the mucoperiosteal flaps are raised, but from the edge of the soft palate cleft, oblique incisions are given to the canine tooth here, and a pushback is done. Here, mainly, there is a pushback and the lengthening of the soft palate. This is the main advantage of BWK pushback palatoplasty. Bardak's palatoplasty, like I told, two lateral incisions are put around the alveolar margin, and mucoperiosteal flaps are raised widely like this, and they are brought to the midline, and here intravelar veloplasty is there. So, Bardak palatoplasty, Vio-Wardle and Kilner's palatoplasty, and Von Langenbach's palatoplasty, they are all hard palate closure techniques. Whereas the soft palate closure techniques mainly involves closure of the oral mucosa, nasal mucosa, and the muscular layer. It is called as intravelar veloplasty. Basically, all palatal closure techniques needs the intravelar veloplasty part also. Here, delamination of the soft palate layer is done, and abnormal insertion of the soft palate muscles into the edge of the hard palate is released, and it is transposed to the midline. This is the double opposing Furlow's technique of Z-plasty, wherein Z-plasty is raised here. The hard palate is not touched at all. So mucoperiosteal flaps are mainly raised in the hard palate, not in the soft palate. That is why I gave the answer of Furlow's Z-plasty. So here, first of all, a mucoperiosteal muscular flap is raised, and mirror image Z-plasty is created on the other side, and the transposition is done and muscle repair is done. This is called as a double opposing Furlow's Z-plasty. In free flap condition, dark bleeding on exploration and thrombus is noted in anastomosis, which is the next best step. Options in case of flap compromise are, first of all, the flap compromise can be because of the arterial perfusion and because of the venous congestion. In free flap arterial insufficiency, there is no question at all. You take the case, reopen and do the arterial anastomosis. Okay. If there is a venous insufficiency, which is more common, okay, first of all, we have to release the stitches. Before that also, the systemic condition is looked upon. First of all, when free flap is done or flap is done and the patient is lying in the post-op ward, first you have to see whether the blood pressure is good, the hydration is good, his urine output is good. These also can cause flap necrosis. Once the general conditions are ruled out, hemoglobin is ruled out, then if you see there is a venous congestion, which is denoted by a dark bleeding, bulged flap, etc. First of all, quickly you have to remove the tight dressings, then try to remove the inserting sutures. Here, by meaning the inserting sutures, the sutures which stitches the flap to the defect. Then you can even prick it serially at the tip alone. Therefore, the congested blood is let out. Okay, and you can even deepithelize a portion of the flap. You can remove the nail bed in case of replantation cases, and nail bed is removed and the draw area is created and the apparent soaked auspice is kept and continuously scratched, and iridomide leeches also can be put up. or sometimes cannulation of the vein and periodically draining the flap. But mind it, all these things are only after confirming that is no thrombosis. Okay. So, if there is venous thrombosis, again the first step is to take to the theater, open and redo the anastomosis. In theater, if we are realizing there is no thrombus, then only all these procedures like pricking the flap serially, deepitalization, removing the nail plate in the replantation or leeches can be done. Okay. So, uh, systemic thrombolytic therapy, heparin, all these things can be done only when there is no thrombosis noted. But when a thrombus is noted, reanastomosis is the drug best choice. Few points on leech therapy. The leech therapy is done with medicinal leech, also called as the Hirudo medicinalis. Saliva. Uh, the saliva of the leech contains hirudin and hyaluronidase and histamine. Hirudin acts as an anticoagulant. Hyaluronidase facilitates the penetration of this anticoagulant, and histamine causes vasodilation. Therefore, there is a lot of bleeding from the flap, which also decreases the venous congestion. Again, the primary indication of leech therapy is not clearing the anastomosis. When the anastomosis is there, it has to be re-anastomosed. Okay. And also for leech therapy, arterial obstruction should not be there. The course of treatment is nearly for 2 weeks till new veins are formed. Each leech can imbibe up to 5 ml and up to 150 ml of blood can be lost. Therefore, frequent transfusions are very essential. One problem with leech therapy is it has Aeromona hydrophila in its intestine and therefore can cause sepsis, and therefore we have to put fluoroquinolone antibiotics. Okay. Every time after putting the leech, we have to remove it. While remove it, since it is having a deep sucker, it will traumatize that area and a lot of bleeding will be there because anticoagulants are. Best treatment for hair alopecia due to excision of lesion or the scalp and placement of STG is tissue expansion. 1 second. Uh, just 1 second. Excuse me, I had some water. Yeah. The best treatment for hair alopecia due to excision of the lesion over the scalp and the placement of STSG is my option is tissue expansion. First of all, hair restoration due to alopecia of any reason, there are two main techniques: hair transplantation and hair restoration surgery techniques. In hair transplantation, we harvest from the patient itself the hair follicles and we graft it over the balded areas. There are two main techniques: strip extraction technique and the follicular unit extraction technique. In strip extraction, the strip behind the balding resistant area, the occiput is taken. Multiple breadloaf technique of cutting is done, and these follicular units are implanted. Whereas in follicular unit extraction, small punch biopsy, which a drill machine, micromotor drill is taken like this, so that a large scar like this is not seen in this case, and those grafts are implanted. So follicular unit extraction is a slow technique, but cosmetically much better. And this follicular unit extraction is nowadays done with robotic technique. So strip extraction, follicular unit extraction, and robotic follicular unit extraction are the three hair transplantation techniques which we know of. One thing we have to be very careful is all the grafts are very having high metabolic demand. They should be having a good osmotic balance, and they shouldn't be kept in a warm place. Cold petri dish, they should be placed in cold petri dish so that the metabolic demands are reduced. Otherwise, most of the hair grafts will fail. There will be loss of the hair grafts. So, bioenhancement solutions can be used till they are transferred into the scalp. For 800 to 1000 follicular units, at least 5 to 8 hours can take. And if 5000 follicular units are done, that is 3000 to 6000 FU is transplanted, it is called as a mega session. one main thing is, even though we are transplanting, the patient might continue to lose his inherent frontal hair. Okay. And several treatments are there to stabilize that by giving PRP therapy or laser stimulation of hair growth, etc. So this is a short thing about hair transplant. There are other procedures called as hair restoration surgery procedures, wherein the balded area of the skin is excised and the hair bearing area is pulled and stitched. It is all very old procedures. Nowadays, nobody is doing. But if there is an alopecia, especially due to the STSG, like in our question, this hair restoration surgery can be done by pulling and suturing. But to pull and suture, you should have enough amount of hair bearing skin. That is why tissue expander is the best option here. If tissue expander is kept in the remaining hair bearing skin, expander is inflated, large amount of skin is available. This skin can be transferred as a flap. Now see what are the advantages. One, hair bearing tissue is transplanted. It is also sensate. There is no donor defect or even scarring like transverse scar or multiple small scars, because this flap itself will close the donor side. Whenever we are doing a tissue expander, we also calculate what is the donor defect and expand it to that level wherein we close the donor defect also. And also, there is no dependence on bioenhancement solution, temperature for the hair graft. The hair graft survives because it is brought there as a flap. That is why, if already STSG is put there, going and doing a hair grafting there is not the best of the options. Sometimes, if no other option is there, they do, but not the best of the options. If already a full thickness or a partial thickness graft is there and alopecia is there, the best procedure is to close that wound by excising that skin graft to the available hair bearing scalp. But if available hair bearing scalp is less, you have to use a tissue expander. Which is the last finding in compartment syndrome? My answer is pulselessness. Okay. To answer this, before that, let us see. Compartment syndrome is increase in the pressure of the extremity compartment. Our extremities are covered by a deep fascia layer, which is a very thick and non-malleable layer. So whenever there is a fracture, hematoma, muscle necrosis due to electrical burns, or venous edema, and there is increase in pressure of the tissue, they can cause ischemia, necrosis, etc. So this is called as a compartment syndrome. We all know it. But how much can the muscle tolerate ischemia? How much can the nerves tolerate ischemia? Theory tells that muscles can at least tolerate up to 4 hours of ischemia, and they can partially recover in 6 hours. So even if they partially recover, they will land up with a Folkman's ischemic contracture. But more than 8 hours of compartment syndrome is there, it will permanently damage. Peripheral nerves has a ischemic tolerance very less. Only within 1 hour it gets affected, and within 4 to 6 hours it gets ischemia. Okay. So these are the various etiologies: fracture, vascular injury, crush injury, iatrogenic compression because of the tourniquet, like constrictive bandage, overuse of tourniquet, prolonged limb positioning, etc. Okay, even drug extravasation due to chemotherapy, bleeding disorders, when there is a tenosynovitis and there is a ascending cellulitis infection, etc. Muscle overuse, exercise, weightlifting, etc. Okay, fractures are the most common uh, process. We shouldn't think that only in closed fractures compartment syndromes can happen. Even in open fractures, compartment syndrome can happen. We should have a high index of suspicion. In forearm compartment, radius or ulnar fracture is the most common, and in hand compartment, multiple metacarpal fracture is the most common. So primarily, when you talk about the clinical signs, pain is the main sign which he is going to tell. Physical pain, swelling, and tightness of the extremity. Sometimes the skin creases vanish, the overlying skin becomes shiny and develops some blisters also. In the forearm compartment, the finger can get flexed like this, and the patient can even have an intrinsic minus position. Intrinsic plus position is MCP flexion, IB joint extension, whereas intrinsic minus is like this. Too much of flexion of all the fingers. So the classical 5P signs are swelling. Okay, after that, pain, paresthesias, paralysis, pallor, and pulselessness, in which the late symptom is often pulselessness, because that is the last thing. Okay, so answer is pulselessness. So if at all a question is asked, which is the earliest symptom? Pain is the earliest symptom. and which is the latest symptom, pallor, which is the irreversible symptom, paralysis. Okay, so other symptoms are there will be severe pain on passive extension of the finger in case of volar compartment syndrome, and there will be severe pain on passive abduction of the thumb in case of thenar compartment. It's all mainly related to the upper extremity compartments. So earliest symptom pain, late symptom is pulselessness, irreversible symptom is paralysis. Once paralysis is there, even if you do fasciotomy, the hand can go for gangrene or result in Folkman's ischemic contraction. Usually, we don't in clinical practice measure the compartment pressure. Even the slightest suspicion of increased pressure, we go for a fasciotomy release. But for theory purpose, the intra-compartment pressure is greater than 30 millimeters of mercury is an indication for fasciotomy. Or if the pressure difference is within 30 millimeters of mercury of the patient's diastolic pressure to the compartment pressure, it is also an indication. Other investigational radiology is not useful. Ulnar nerve injury with a 1 centimeter gap, best treatment is. So, in sharp, clean cut wounds, primary repair is the best treatment. Because if you leave it, there can be retraction and there can be requirement of the nerve, what do you call it, nerve grafts, etc. Here in this question, they have not given whether it's a acute ulnar nerve injury or a chronic, and they have not given the few details like whether this 1 centimeter graft is after mobilization, because some amount of mobilization can be done with the wrist kept in 30 degrees of flexion. Since those details are not given, I think the primary opinion should be nerve graft, because any nerve repair intention is bound to go for a failure only. So whenever the nerves are not approximatable, you have to go for a nerve graft. But initially while debriding, there is a gap. But with the wrist to 30 degrees, there is no gap means. So that then you can do a primary repair. So basically, the question which we have got is whether this is after mobilization. How much mobilization? Then not more than 1 to 2 centimeters of mobilization and not more than 30 degrees of flexion of the wrist should be done to oppose the nerve ends. So my answer will be nerve graft. Because nerve grafting is the gold standard. For digital nerve, posterior interosseous nerve, sensory portion can be used. Even medial antebrachial cutaneous nerve can be used. For large nerve groups like median nerve and ulnar nerve, sural nerves can be used. And sometimes a decellularized nerve allograft is also used. Post-operatively, after nerve graft repair, at least the hand should be splitted for 3 weeks. And tinal sign, progressive tinal progression is a very good sign of good nerve repair. Yeah, advancing tinal progression is very important. Here, image of the tram flap was given, and based on which artery the reconstruction was done is asked. So basically, transverse rectus abdominis muscle or rectus abdominis muscle is superiorly supplied by superior epigastric, inferiorly supplied by the deep inferior epigastric artery. Okay, deep circumflex iliac artery gives a Rubens flap that doesn't come here at all. Superficial inferior epigastric artery can supply, but that can supply only in as a free flap. Superficial inferior epigastric. It is not superior epigastric. Okay, mind it. It is not superior epigastric. It is superficial inferior epigastric. Can supply the tram area only as a free flap. So here I will just go through the few contents and come for the answer. Breast reconstruction can be done by either a autologous or a prosthetic technique. In prosthetic technique, tissue expander placement with lead exchange is one option. Immediate permanent implant placement is another option. Latissimus dorsi muscle underneath implant. So these are the implant-based technique. Autologous techniques, two techniques are there: pedicled technique and free technique. Okay. In pedicled technique, okay, the tram, if a pedicled tram is being done, it has to be from the superior epigastric artery and vein. So in this particular question, if it had been given superior epigastric, I will tell superior epigastric as my answer. Okay. But the free flaps are mainly, okay, deep inferior epigastric artery flaps or superficial inferior epigastric artery flaps or muscle sparing tram flap. Let us see here. Here, you can see here as a free flap, this part of the fat is taken, the perforators are identified, deep inferior epigastric artery perforator is chased and this flap is taken. Okay, here some muscle is taken, here muscle is not at all taken. If muscle is not at all taken, it is a deep inferior epigastric artery perforated flap. If some muscle is taken, it is a muscle sparing flap. It has been found that in some cases, 30, 10 to 20 cases, 20% cases, the superficial inferior epigastric artery, which we usually cut in hernia, does supply this infra-abdominal fat and can be used as a free flap. So, in this question, okay, in this question, if they have given a pedicled tram, then none of the then probable answer will be superior epigastric. This might be superior epigastric. Okay, but if pedicled, if a free flap is given, deep inferior epigastric is the answer. But anyway, deep circumflex iliac is not the answer. Sometimes superficial inferior epigastric can supply a free flap. Other free flaps are gluteal based flaps, S gap flaps and I gap, superior gluteal artery perforated flaps and inferior gluteal artery perforated flaps. In a patient with absent pectoralis major, minor, and ipsilateral syndactyly, what is the syndrome? It is a Poland syndrome. One of the commonest chest wall deformity syndromes, absence of pectoralis major and minor muscle, absence of the anterior portion of the ribs, 2 to 5 ribs, loss of LD flap, LD muscle and serratus anterior muscle, loss of axillary hair, limited chest wall fat, and therefore absence of breast. Brachysyndactyly can be there. Brachydactyly means shortening of the hand. Syndactyly means fusion of the fingers. So brachysyndactyly of the ipsilateral hand is there. Breast hypoplasia of varying degrees can be there, and nipple areola complex is absent. Okay, this is a typical case of Poland syndrome. Treatment is, but out of the various features, the most consistent feature is sternal costal head of the pectoralis muscle is absent. Okay, treatment of the correction of the contour deformity is either with pedicled LD flap, but even if the LD muscle is lost, then we cannot do it with it. So rectus abdominis muscle flap or a tram flap can be done. Sometimes even a prosthetic chest wall and breast reconstruction has to be done with a prosthetic silicone material. Whatever said and done, the reconstruction is usually deferred until the late adolescence because otherwise you have to do the reconstruction according to the size of the contralateral breast and you might have to continuously revision the reconstruction. Instead of that, let the other breast achieve the proper size and after that you can reconstruct this. After 3 hours of forearm surgery, patient is unable to extend the fingers and the wrist. What is the option? Radial nerve neuropraxia due to improper padding, radial nerve neuropraxia due to prolonged tourniquet. So even after improper padding, if the duration is for 3 hours without deflation, then it is bound to create a nerve compression, and especially the radial nerve compression is more common in the forearm, in the humerus. So again, I would like to reiterate, like skeletal muscle can tolerate 4 hours of ischemia, but peripheral nerves cannot tolerate 1 hour of ischemia also. So in tourniquet surgeries, cuff to be selected should be as wide as possible. Systolic pressures, I mean standard pressures more than 100 to 150 above the systolic pressure should be used to inflate. And the cuff is deflated once in every 2 hours for at least 15 to 20 minutes. And that is every 5 minutes for a reperfusion of every 30 minutes of tourniquet time. And examination can be performed in all cases except those of the infection or the tumor. This brings the end of my question discussion. Okay, hope the discussion was useful. I'll be submitting the PPTs. So, Thompson's procedure is also called as buried subdermal flap is the first option. Just I am okay, summarizing it. The procedure for cleft palate, which has to maintain the levator sling without raising mucoperiosteal flaps is double Z palatoplasty, also called as Furlow's palatoplasty. Free flap congestion occurs and thrombus noted. Next best step is take down the anastomosis and take down the thrombosis and do the reanastomosis. Best treatment for hair alopecia due to excision of a lesion and placement of STSG is tissue expander. The last finding in compartment syndrome is pulselessness. The first finding is pain and swelling. Ulnar nerve injury, 1 centimeter graft, nerve graft is the best option. For a tram flap, a pedicled tram, superior epigastric artery is the pedicle. Free tram DIEP is the pedicle. Sometimes superficial inferior epigastric artery is the pedicle. Easiest patient with ipsilateral brachysyndactyly, pectoralis major and minor abscesses, Walland syndrome. And finally, the after 3 hours of forearm surgery, the patient is having a radial nerve palsy. It is not because of improper padding; it is because of a prolonged tooth decay. So, for every half an hour, for every 2 hours, at least 15 to 20 minutes of deep perfusion is required. Thank you.